So I'm always happier to talk about critical care topics rather than managerial management related topics. Unfortunately, I'm also the medical director of a hospital, so now I get these administrative topics. But it's probably of interest to all of us, and particularly senior colleagues who run hospitals. And for a Bengali to teach a Gujarati how to run a hospital is a dangerous task I have been given. So what are the challenges of attrition in Indian ICUs? Obviously, you know the challenges. One is high turnover rates of nurses is about 25 to 50%. My hospital somewhere lies in the 20 to 25%. And not only will I talk about the maintaining staff competency, but how can we reduce the attrition also somewhat, I'll be talking about. But many hospitals I know are reaching turnover rates of nurses, attrition rates of about 50%. That means half the nurses leave the hospital in a year. And for residents, depending on the specialty, the studies have shown anywhere between 12 to 30%. This is from PGI Chandigarh. And so obviously it impacts the competency because there's a loss of institutional knowledge and a constant flux of inexperienced staff requiring training. This leads to patient safety risks because of staff shortages leading to nursing ratios being inadequate, resident ratios being inadequate, and also improperly trained staff. And in the Indian context, it gets even worse because not clear-cut guidelines for ICU staffing is not yet in place, probably. So what can we do? So the first strategy would be, it's called robust and accelerated onboarding. I don't consider myself an expert on this, so I would like other people's opinion at the end of it. I'll tell you what we do, what I have read, and what we actually do in my hospital, and you can tell your experiences also. So a structured program, that's what we surely do, is implement. We have a formal structured training program for nursing, not so much for residents, but for nurses, we have a training program, orientation. It's not just an orientation program, but a continuing training program for almost 6 months in the ICU. Over and above, this is over and above the continuing education, nursing education that goes on, or the resident education that goes on. We have a continuous initial training program. The other thing which we have found very useful is mentorship and preceptorship. So you attach a young new nurse or a resident to a more senior, brighter, competent nurse or resident, depending on who you are training. And this pair works together for a certain period of time. Usually our preceptor model is for 1 month on the floor and 3 months for nurses in the ICU, 2 to 3 months, depending on our staffing and the patient load. And not only do we, so the preceptor takes the new trainee along during this period and shows him or her the way to do things, and laying clear milestones that what do we expect this nurse or resident to learn in the first 30 days, 60 days, 90 days, up to 180 days, because this is a 180-day program that we have. Okay, a clear path. We need to know what this person is expected to learn, and is that person learning or not. One thing we do is that a nurse, if within a month or two, 30 to 60 days, they don't seem to be competent to work in the ICU, they are not catching up to what we expect, we tend to move them out of the ICU. We put them in other sites. We don't take them in the ICU. Okay. Early feedback loops, very, very important. Feedback from them, from those people and the preceptor to understand where are they finding difficulty in learning and training. Okay. Now, the other is how do we innovate the training and make it as far as possible continuous. So role-specific training is very important. So the nursing side tends to have a lot of training for non-critical. So if we are talking about the ICU, non-critical care related training also. So they have lots of classes for other things also. But in the first few months now, what we have done is train the ICU nurse to focus on role-specific in the ICU, what they need to know most. Okay, handover, etc., being probably a little secondary, but mostly focusing on the task at the bedside. That's what we try to do. Simulation training, we do it, but not very good at it yet. We want to do better on that. Like, you have a situation like a tracheostomy change. We are going to change a tracheostomy. We convert it into a kind of a intense training for the new nurse to show if the tracheostomy got dislodged, what would happen? So that's what we try to do. So this is called high fidelity training. Okay, so we try to do that. And bedside teaching frameworks, where again the preceptor, this I think we have found it very useful. There are different terms used, 5 minute, 1 minute preceptor model. So what we do, so we don't take the preceptor, so there are these theory classes, but what we found very useful, the preceptor just collects the people when there is a slight decrease in workload around the bedside to teach them something like line care or suctioning. Just 5 minutes practical hands-on how to go about it. So this is called the 5-minute preceptor model, which we use, which we find very useful in training our nurses particularly. Blended learning, that's combining e-learning modules with flexible self-paced foundational knowledge, etc., along with hands-on sessions. We are not very good at, I am not, in my center, we are not yet very good with digital, but bright young people, and you are very great entrepreneurs here, you could do this better probably. And hands-on sessions we do much more, but we don't use digital learning modules yet as much as one should, I think. Procedural skill frameworks. There are many, when I was reading up for this, so there are many mechanisms of doing it, like you have this process. We kind of do it, but never documented it in this fashion, that first the person reads about what they are going to do, about a procedure, then see somebody doing it, then practice it theoretically, verbally, then prove to you that they can do this, and then actually go and do it, and then maintain that competency. This is the model that is supposed to be used. We don't go by that algorithm, but this is a good learning that I had as an administrator, that probably we should be doing this. And also, then focus on the non-technical skills. It's very important, which we miss out on. 3 things: communication, closing the feedback loop. I find it very problematic that, if you see the ACLS guidelines, etc., from the AHA, you will see that they always say, speak out what you did. And then, so that everybody in the team knows that you had been assigned a task, that you have to give adrenaline, 1 milligram, given, flush, given, right? So that's the ACLS. It's not just for ACLS, it is how the practice of any crisis situation should be in the ICU. And for other things also, giving the feedback, closing the loop of communication, that what has been told to somebody has been done and informed back to whoever it is, to the senior or the colleague, etc. This is absolutely important. And learning teamwork, I'll come to that later. The other thing is situational awareness. It comes from martial arts. Situational, all around you should know what's happening all around you. Right? So the tendency is, after the morning rounds is over, the consultant's watch is over, I'm not blaming them. So what tendency is that then they walk around in the ICU like they are company baag ke sair kar rahe hain. You have to be constantly aware of what is happening around you. Which monitor is beeping, which other patient. You don't ignore and walk past as if nothing is happening. Always there is something happening in the ICU. You have to be aware. That situational awareness of not only one patient, that patient for the nurse, but or the resident, all around what is happening, you have to be watchful. And that is, you have to train people to that. Situational awareness just doesn't come like that. Different people have different capabilities. That is one training which is very essential, I think. Strategy 3, knowledge retention, so that you mitigate the loss of expertise. So what do you do? Document protocols. Protocols have to be documented. I find the nursing, for the nursing side, the nursing chart can be a very good document. On the front page and the back can give all the necessary required things that the nurse needs to monitor, and and checklist. And that itself can be a very good document to train the nurse on. I'm just giving one example. There should not be too many documents. If you give too many documents to learn on, people will not learn. So I found that a good comprehensive ICU chart is a good place to start learning and maintaining their knowledge. Culture of knowledge sharing, okay? If you know something, share it. The tendency here is a young person comes in, asks a question, and you say, "Arey, tere ko nahi aata ye?" The person is not going to ask a second question. That's the worst thing that we do. We have to be much more open-minded, allow people. This is the time they will learn when they're young people, and they're not going to learn at my age, So you have to allow them that space to learn at this age, okay? Team debriefings, we do, but we don't do as much as we should. I think it's a very good idea. Whenever we have done team debriefings for a crisis situation where we probably messed up, having a debriefing to what went wrong. And also most important, as a leader also to accept your misses. You should be the first ones to say, maybe I missed this, what do you think you missed? If you finger point at others that, then the tendency is to clamp down, not say the right thing. People will not come out honestly. It's very important to come out honestly between the team. Maybe not the patient family, etc., that's a different thing. But within the team, you have to be honest to yourself, and the leader has to take a role that they should be the first one to acknowledge if they have made a mistake or slipped in some way. Exit interviews, very important. If somebody is leaving, ask them why they are leaving. They will many a time say, no, I have got this opportunity, that. But just say, okay, suppose you continued here, what are the things you would like changed? And that has helped us a lot. The exit interviews have helped us a lot to retain our staff. So, optimizing staffing ratios. Always fight with your administration, if you are not the administration, to get optimal staff ratio. If you ask for 100, you will get 70 probably, but keep pushing it. Keep pushing that optimal staff ratio as much as you can, okay? In every way, nursing, resident, etc. Again, promoting teamwork, working together, being inclusive, non-intimidating, checking, allowing every team member to give their opinion, particularly during rounds, etc. I do some of it. I'm not great at it, but you should try and be as open to suggestions from others. Sometimes we are in a rush to do the rounds. We don't take other people's opinion, but we should look around and ask, what do you think? Particularly the resident who's looking after the patient and the nurse at the bedside. We don't take the nurse's opinion as much as we should. What do they feel? Okay? Open communication, same thing. Effective leadership, as I said, being open to listening to people, positive feedbacks, talking if somebody is not performing well, taking them, not kind of demeaning them in front of others, taking them aside to talk to them, okay? But also one very important fact that we miss out on sometimes is a strong ethos of fair play. Favoritism, evidence has suggested that chimpanzees and little babies even recognize unfairness. You'd be unfair to your staff, they will, even chimpanzees, I'm not joking. There's enough studies to show that. If you're unfair to people, people will know that you are very biased. Once you are biased, your leadership position drops down. So be very careful about bias. Even if you have a fondness for somebody, you cannot show it as a professional. Sorry. So, okay, I think recognition and rewarding good work, positive, the carrot, and making them develop a pride in the institution that they're working on, the department, and in their own work. Compare yourself, look at the international data or the national data for certain thing and say, look here, we are doing this is our mortality rate, this is our SMR, standardized mortality ratio in the ICU, or our VAP rate, or whatever, our CLABSI rates. And this is the international one, this is our local, Indian one. So we are performing well, but we can do better. Things like that. That we are doing a good job, and we can be better, always. We are doing a good job, but we can be better. This building a pride, because a lot of people, particularly the younger staff, don't get the fat salaries that many consultants do. Their stimulation has to be academics, their commitment, their quality of work has to be the stimulation. Rehumanize the workplace, Again, adequate rest periods, very important. This you have to fight with the administration to get it. Good staffing ratios, rest periods, very, very important. And psychological support whenever needed. Then, building autonomy. You realize that this person is capable, okay? This is a capable person who is ready to take responsibility. Slowly give them more autonomy and responsibility to take at every level, at the nursing level, residence level, young consultants level, if you are, And this would lead to what is called a succession plan. In case you have some attrition, the next person for you is ready to take over, right? If you give autonomy and responsibility, when you identify leaders within your team, then you can hand over that responsibility, even if you have some degree of attrition. And that itself leads to clear career paths for people. People should be looking at, okay, if I do this well, I may get to the next level, next position. They should understand that good work will lead to your certain position, that there's a clear career path. The most difficult one, competitive compensation, salaries. We cringe on the salaries to our residents and our nurses, okay? It has to be competitive. Competitive, I'm not saying that your salaries have to match UK salaries, but it has to match at least the local payouts. And what we did a study in our hospital, and we realized just increasing the salary in the among the nurses when they joined by 3,000 rupees, made the competition go down below us. Most of the competition. We could not compete with the Middle East or Europe, but we could compete with all of the private hospitals. We could not compete with the government. The Delhi government salaries are very high. So, but we identified which are the areas we need to be competitive. So senior resident level, we were not finding people. We became competitive with the government also, salaries. Junior residents, not so much. I'm just giving you how unfortunately it works. At the nursing level, we found that nursing salaries we could not compare with government salaries, but the contractual government salaries we could compare with, and private salaries, private hospital, we just went a little up. Investing in that, our attritions have gone down, our quality of care has improved. All this, you have to give larger vision. Sometimes the administration who's not a doctor may not understand this. So you have to explain to them how this helps the hospital and quality of care and the reputation of the institution. Because sometimes you are looking, the administration or the management looks at the bottom line, but you have to explain to them how it helps the bottom line in the long run, or the top line in the long run, so that the bottom line comes up, okay? So competitive competition, okay. So just to conclude, so a proactive approach, you have to look and watch as a leader, what is bothering your team? What are the main factors? Exit interviews are a very good way. Keeping an open communication is a very good way to understand what is bothering them and approach that in a certain way with training, knowledge management systems, etc. Invest in people. Be good to people, kind to people. People are ready to take, like on the rounds, I can be brutal. I am brutal. Anybody who has worked with me knows, with Rag knows. But that is only during the rounds at the patient bedside. But outside, just off that, you have to be kind. You have to be kind to people. You have to take them along. Because you cannot be a great intensivist if you don't have a good team. You are as much, alone, you are nothing in critical care, to tell you honestly. Even with your greatest brilliance, you need the team. So you have to get the team along. Multidisciplinary effort, obviously, and a vision to take your institution and your department to a certain level. That vision should come from the leadership, where you want to take it. You don't want to do just the daily thing. That is not attractive to young people. You have to tell them where you want to take this institution to. So that's very, very important part of what we do. Again, as I said, develop a pride in the institution, the department, and for the work they do. Thank you so much.
Thank you, Sumit bhai, for completing before time and making this non-medical topic very interesting.
Thank you.
For the next session, I'll invite Dr. Samir Patel, and the topic is practical difficulties in end-of-life care implementation in India. This is also an important issue to be addressed in our day-to-day ICU practice. And for that, I invite panelists. I invite Dr. Gopal Rawal, Dr. Amrish Patel, Dr. Ritesh Shah, and Dr. Sunil Chhajwani.
Dr. Samir Kumar Patel is MD Internal Medicine and is a EDIC European Diploma in Intensive Care. He is a Professor, Department of Critical Care and Internal Medicine, Sri Krishna Hospital, Baikhalla University, Karamsad. And his area of expertise is ultrasound in critical care, NABH, and hemodynamic management. We start with you.